Yes.
Are you going to introduce me? Hey, I'm your Okay, good. It's fine with me. I mean, it's up to you. It's your conference.
So unfortunately, Yorm can't be here because of a death in the family, so I'm his substitute. I'm going to introduce Dr. Van Hare, who is the director of the David Goldring Division of Pediatric Cardiology. He's the Lois Larrick Ward Professor of Pediatrics and the director of the Pediatric Arrhythmia Service at St. Louis Children's Hospital. And Dr. Van Hare moved here recently in the fall from a joint appointment at UCSF and at Stanford. And here he plans to continue multi-center clinical research looking at pediatric heart rhythm disorders, biology of atrioventricular node reentry, mapping and ablation of post-op atrial and ventricular tachycardia. And that brings us to today's talk, which is developmental aspects of atrioventricular node reentry tachycardia, AV and RT.
Thank you very much. So I'm very sorry to say that this is actually my first attendance at this seminar. It's been on my calendar on a weekly basis ever since I kind of arrived here, and somehow just not been able to make it over with all the clinical stuff and faculty meetings and all the rest that I get to do. But I'm very happy to be here and hope to attend the seminar on a much more regular basis in the future. I have to tell you that I'm quite insecure about giving this talk to this group of people because I really feel that AV node reentry is something that I fundamentally don't understand, and I think a lot of us who do clinical medicine sort of feel the same way, and I'll just sort of admit to that. And I got over my insecurity by saying to myself, well, okay, fine, so I'm going to talk about this stuff, and you guys who actually know a huge amount about sort of basic electrophysiology are going to be able to actually tell me where I've really gone off the tracks, or where I, or where I haven't really sort of thought of something. So what I'm really hoping to do is going to get a lot of feedback and advice about this basic clinical problem. Anyway, so AV node reentry is this. Is this a pointer here? Is that what this is? Okay. Oh, perfect. Right. Okay. So there's an electrocardiogram showing AV node reentry. The characteristic feature is narrow complex tachycardia. For those of you who aren't involved in clinical medicine, there are no P waves that are evident, and the reason is that the P waves, in fact, are superimposed on the QRS. This is a very common form of SVT that we see in teenagers, young adults, and sometimes in younger kids. Actually, my first case in the EP lab today was a little 13-year-old young lady with this particular problem who we did a catheter ablation on. So our models about what AV node reentry is have really kind of evolved over the years. When I was a fellow, which was 1988, 89, this is basically how we thought of AV node reentry, and not to kind of drag you through the details, but fundamentally a black box concept. The concept was that you have two pathways through the AV node. One's a fast pathway, this is drawn here, and this is a slow pathway with a sort of squiggly line. And the concept was that this was not really an anatomically based concept, but really a functionally based concept. You could define fast conduction and slow conduction through the AV node, but there was really no way that you could sort of differentiate anatomically where the fast and the slow pathway was. Nowadays, we have a somewhat different orientation, and here are just two drawings from two different papers in the last decade that kind of talk about our current concepts. And we now know that the slow pathway, which supports AV node reentry, can be approached or can be ablated in a region fairly close to the coronary sinus, in sort of the posterior inferior portion of the interatrial septum. And the fast fibers, the fast pathway tends to be more anterior, but in fact it's quite a bit more fancy than that. And we now know that we have posterior AV nodal extensions, meaning little bits of AV nodal tissue which extend into various parts of the heart, some of which can actually be over on the left side. In fact, you have left-sided atrial extensions. And so it has gotten somewhat more complicated, but we now basically have sort of more of an anatomic concept. But I will still make the argument that that although we know that we can ablate the fast pathway up here and the slow pathway down here, what actually happens in the AV node, as far as I'm concerned, is still something of a black box. And I'll hope to make that argument for you as we kind of go through here. So for those of you, again, who aren't electrophysiologists, I just want to go through how we actually define this concept of AV node reentry, which, as I said, is a form of SVT. The classic way of defining it is as discontinuous AV node conduction curves. And what I mean by that is that when we pace and put in premature beats, we are basically measuring the conduction time through the AV node. And we know that for any sort of 10 millisecond decrease in the coupling interval of the premature beat, there is sort of an expected gradual increase in conduction time that occurs. And that tends to be a fairly slow curve, but some patients will have a discontinuity in that conduction curve. And a jump is defined as about a 50 millisecond increment or greater in that conduction time, typically A2, H2, which is the way we define that. And in practice, in fact, the 50 millisecond jump is sort of the minimum. Most of the time we see a 100 millisecond or 120 millisecond jump. We also sometimes will see a second kind of jump, which is just when we do straight pacing from the atrium. There will be a phase where we will suddenly transition to a situation where the PR is actually greater than the RR. And what I mean by that is that any given atrial electrogram is leading to a ventricular electrogram that's after the following atrial electrogram, so it sort of skips, so that the conduction time is even longer than the drive cycling. We have echo beats on A1, A2s. We can induce a sustained AV node reentry typically, and the criterion is a VA time, very tachycardia of less than 50 milliseconds. And then there are some mapping features that in tachycardia, the atrial electrogram adjacent to the His bundle tends to be the earliest that one can record in the heart, and specifically slightly earlier than at the coronary sinus os, which is again where the slow pathway is. So the concept is we're going up the fast and down the slow. Here's a typical conduction curve, and actually this is pretty typical for what we see. In fact, I took this off of one of my patients. And so the curve basically shows the coupling interval here on the x-axis. This is basically the degree of prematurity in milliseconds, and so generally we start out here at 400 or 500 milliseconds, and we come in 10 milliseconds each run, and at some point we suddenly have a dramatic increase in A2H2, which is the conduction time through the AV node. And but as I said, this is pretty typical in that, see, we go up here, and then another 10 milliseconds, we have another jump. So where's the jump? Is it here? Is it here? Or the two jumps? Kind of depends on how you define it. But at this point, we start to develop echo beats, meaning that we've blocked in the fast pathway integrate, and we're coming backwards up. We've blocked in the fast pathway, and we've gone down the slow pathway, and we're coming backwards up the fast pathway, and that's where the echo beats start there. But then we have this nice little continuing conduction curve here, where we continue to be on this sort of new curve. So the general concept is here we're on the slow pathway, here we're on the fast pathway, here in the middle, not sure. Don't really know. But this is fairly typical, like I said, for these patients. Also typical is this, which may cause us a lot of trouble. We recognize this a lot in children and in teenagers, the lack of discrete jump. And so here's the conduction curve in a patient who actually has AV node reentry. as we march our way down A1, A2, at some point, we start to develop echo beats, and the conduction time through the AV node, the A2, H2, is very, very long. But we don't really know in this conduction curve where we stopped going down the fast and started going down the slow. We just don't know where that transition takes place, okay? And that creates a diagnostic problem for us, but this is sort of what we see often in kids. But just to sort of show you some tracings in terms of what we look at in the EP laboratory, surface ECGs up here, basically 4 surface ECGs, high right atrium, His, coronary sinus, and RV. As you can see here, here's a single PAC that's dropped in, and you can see here's the A, here's the H, and here's the V, and a relatively short conduction time through the AV node, meaning that we're going down the fast pathway. The very next one, slightly earlier, suddenly increases the conduction time. The concept is we're blocking in the fast, going down the slow, but still no echo beat. But then as we continue on down, we hit one that's earlier still, and this earlier one now has a lot of conduction delay, and now we've set up this reentrant rhythm here where we're going down slow pathway up the fast, and I don't know if you can appreciate it, but there is in fact an extra electrogram here on the His, which is due to the retrograde HL activation. So fairly typical concept. So when we talk about catheter ablation in AV node reentry, in fact, when we talk about anything in medicine and we want to intervene in some way, we have a duty to really try to understand whether our intervention is going to make any difference. And for that reason, we need to know something about what would happen if we didn't intervene, and that's called natural history. And so the question is, what do we know about AV node reentry? Now, I have to tell you, back when I first started hanging out with Yoram Rudy, I actually was in Cleveland, and my job involved being in the pediatric EP lab 1 to 2 days a week, and being in the adult EP lab 2 days a week. And so I do exactly the same stuff. I do SVT work and catheter ablation in the pediatric lab, and then I walk over and do the same stuff in the adult lab. And I recognized very, very quickly that AV node reentry is a weird disease, and I didn't really understand it. And one of the things is I would see these people, there's a substrate for tachycardia. You would think it's something you were born with. But I'd see these people who are 50 and 60 years of age and never had SVT in their entire life. They come in, and suddenly they have AV node reentry. Where did it come from, right? But then I'd go over to the pediatric laboratory, and I'd see kids who had started having their episodes at age 3, or episodes at age 6, or at age 12. So there's something very different kind of going on. We don't actually know whether AV node reentry is something that you're born with. The basic structures are all there in, as far as we know, most people. So how do you get AV node reentry? How does it actually happen? And that's kind of what I've been wondering about for a long time. We don't really know about the natural history, and the reason is, unlike other cardiac conditions that you can diagnose at birth and then follow, like VSD or an atrial septal defect, or even Wolff-Parkinson-White syndrome, this is in fact not something that's clearly present at birth. It's nothing you can identify at birth. And it's actually worse in that we may in fact identify SVT in children, but a lot of times we never do EP study. And in order to actually tie down the diagnosis of AV node reentry, you really need to have catheters in the heart. And we often don't do that in 6-month-olds, 12-month-olds. So it's certain that there are kids out there who are young, who have AV node reentry, and we don't actually know what the diagnosis is. We're just treating their SVT. And so we really don't have any natural history studies on AV node reentry. So we in fact don't know whether this is going to go away on its own spontaneously. We know that WPW does go away spontaneously in newborns. And we know that beyond age 5 or 6, it's unlikely to go away spontaneously. But we really don't have any natural history, and we're unlikely to get natural history because as soon as we actually see this in the laboratory, we tend to try to fix it, and so we're not going to get a natural history study. As I said, older children with well-documented AV node reentry are getting EP studies and ablation, so they're unlikely.
What is TE?
Yes, TE. Where?
TEEPS.
Oh, okay. So that's a little pediatric sort of concept. So it's called transesophageal electrophysiology study. So when normal electrophysiology studies are done with intracardiac catheters, when you're dealing with a little baby, you'd like to minimize the amount of catheters you can place in the heart, and we can in fact get a free catheter, quote unquote, by putting an esophageal lead down. The esophagus is close enough to the left atrium that we can actually record from the left atrium. We can actually paste the atrium from the esophagus, and so we can actually do. So there are places, not this one, but for instance, Boston Children's Hospital, where they do a lot of these. They take them to the laboratory, put an esophageal lead down, and do program simulation from the esophagus, and actually define this. But even with TE electrophysiology study, it's hard to define AV node reentry. The recordings just aren't good enough. Anyway, as I said, my general impression is that children are different. The age distribution is interesting. In the adult population, leaving aside atrial fibrillation, probably the most common form of SVT is AV node reentry, right? From what we know about the incidence, what little we know about the incidence of SVT in children, AV node reentry is actually remarkably unusual under the age of 5 or 6. I've seen a couple of babies, but we just don't see it. Most SVT in kids in the first couple of years of life is going to turn out to be a WPW or concealed accessory pathway. As they get older, the age distribution starts to shift. And by the time we get to be a teenager, probably half and half. Half of them are accessory pathways, half of them are AV node reentry. We also recognize that their conduction curves are really quite different. And it's often very difficult to induce them in the laboratory. Some of that's probably general anesthesia. Some of it is part of the basic condition. Anyway, so just to kind of go through how we fix this, just so you sort of know what we do if you don't know. We tend not to ablate during tachycardia, meaning we tend to ablate during sinus rhythm. We place a catheter in the heart and we look for a particular type of potential that is a characteristic potential for being near the slow pathway. And here's just an example of what we tend to look at. This is called the Hare potential after an adult cardiologist in Bordeaux, as it turns out, France. Typically this is a type of sort of slow pathway potential that's often recognized. Turns out you can actually, this is sort of in my theme of AV node reentry being a black box. Unlike Wolff-Parkinson-White syndrome, where there's a very characteristic potential that is in fact the potential from the pathway, with AV node reentry, this is a non-specific finding. You put a catheter in this part of the heart in somebody who doesn't have AV node reentry, you get the same stuff. When Hare originally published his paper, and Sonny Jackman also had a different type of signal that he published, their hope was that they were identifying a specific electrogram that in fact defined the basic problem, and that's in fact not the case. So this is just sort of a general non-specific finding from that part of the heart. So it gives you some sense that you're at the place where you're likely to have success, but it really doesn't give you anything more than that. But this is typically what we will try to record on our catheter. Here's just an example of what the catheters look like in the heart. Here's an LAO view, and you can see a coronary sinus catheter coming in here, typically right around the coronary sinus and close to the septum here. Probably the coronary sinus is around here, and here we are kind of adjacent to the coronary sinus with an ablation catheter. That's sort of how we do this fluoroscopically. Okay, I should just sort of talk a little bit about general success rates. We've done a large national multi-center study looking at all forms of SVT and use of radiofrequency. And basically, success rates are very, very high. Complication rates are very, very low. The principal complication is heart block, which occurred in our large multi-center study at a rate of about 2%. But subsequently, with the advent of cryoablation, this should be essentially gone. Okay, so I just want to sort of transition now into talking about some more details about the electrophysiology and what we observe. And again, the theme here is AV node reentry as sort of a black box, and what we can maybe learn about the basic mechanism of AV node reentry from observations that can be made in the electrophysiology laboratory. So there is this concept of when you do an ablation and you eliminate the slow pathway, there is an effect on fast pathway refractoriness. So just to take you through this, the substrate for AV node reentry involves a fast pathway with a long refractory period, as we said before. Actually, I didn't say that before. So what happens is you have a fast and a slow pathway. The fast pathway has a long refractory period, and we tend to block it easily with a premature atrial contraction. The slow pathway actually has a very, very short refractory period. When you block in the fast pathway, it allows conduction down the slow. That's the functional separation of the pathways. The slow pathway has a short refractory period. And initially, back in the old days, meaning 1988, 1989, 1990, when we started to do catheter ablation, it seemed fairly obvious that we would want to leave alone the pathway that had the short refractory period. Makes sense, right? We want something that's going to consistently conduct. Consistent conduction means a nice short refractory period. And the pathway that we want to get rid of is the one that's unreliable, the one with the long refractory period. So initially, the fast pathway was an initial target for ablation. And there was a prediction that if you in fact targeted the slow pathway and left the fast pathway, you'd end up with kind of weakened dizzy AV conduction because of the long refractory period. But it turns out that actually didn't happen. The other thing that happened along the way was we initially did fast pathway modification, what we called AV node modification. And those fast pathway ablations, in fact, led to late appearance of heart block at a kind of a very high incidence of like 10 or 15%. And so in fact, just the opposite occurred. In fact, what we found, or what people found, what Sonny Jackman found, and others who started doing slow pathway ablation, was that in fact you see shortening of the fast pathway refractory period if you target the slow. So here's, again, this is about as typical or classic an AV node conduction curve as you're going to see in an AV node reentry patient. Again, this is a little similar to what I showed you before. A1, A2 here on the x-axis, so that's your degree of prematurity, starting at 500 and marching on down. Your conduction time is here on the y-axis, which we define as A2, H2, conduction time through the AV node. And you hit a critical cycle length here, and you suddenly jump to a slow pathway, right? So we say is that the ERP of the fast pathway is here at 360 milliseconds. Go ahead and you do your slow pathway ablation. Eliminate the slow pathway. You would think that you would be left with a fast pathway ERP of 360 milliseconds, and that would be now your AV nodal ERP. But that's not what happens. Here's actually what happens. What happens here is that the fast pathway dramatically improves. If I want to use that value statement, it certainly shortens. So we end up with much more reliable conduction down the fast pathway. So what happens? There's some effect of the ablation or effect of the loss of the slow pathway on the function of the fast pathway. And that's kind of a window into AV node reentry. So people have reported this for a long time. Here is kind of just a counting up of a bunch of different studies done in the early days of catheter ablation. The first reports of AV node reentry ablation were from Sonny Jackman in '92, and then a whole series of these for the subsequent decade. And here what we're doing is we're comparing the fast pathway refractory period prior to ablation and after ablation, and the difference and the mean change. Those are two different numbers. And in general, you can see that in general, you shorten the refractory period of the fast pathway by somewhere between 10 and 40 or so milliseconds, or thereabouts. The interesting thing is that if you do total autonomic blockade, which means you give propranolol and atropine, these effects are still seen. So you can't blame this on some weird autonomic effect created by the fact you've been on the table for a long time, or you've been causing pain, or the patient is dehydrated, or a number of other kind of possibilities. And that's something that Andrea Natali demonstrated. Also, Geller, this is work that was done actually in Cleveland, did this painstakingly measuring ERPs before and after every single RF lesion, which would tend to subtract that effect of that autonomic effect. It basically found the same observation. So what's going on? So the proposal has been electrotonic inhibition. The concept is that you have passive current flow due to voltage gradients between cells, and that this passive current flow may in fact lengthen the refractory period of the adjacent cells by maintaining the depolarization or causing a sub-threshold depolarization. So this is the concept of electrotonic inhibition of the slow pathway on the fast pathway. So the concept is while you're conducting down the slow pathway is keeping the fast pathway from recovering. Okay, so it's that passive current flow from the slow pathway into the fast that is keeping the fast pathway still refractory, keeping it from recovering. So it's the presence of the slow pathway conduction maintains a long fast pathway ERP. And when you eliminate the slow pathway, you've eliminated that effect, and you've freed the fast pathway from its from that inhibition, and allowed it to repolarize as quickly as it normally would repolarize. And therefore, it shortens its refractory period and improves. And that's why you get away with ablating the slow pathway. That's what the concept is. Okay. It actually has been modeled with a computer model, and this is well beyond my my area of expertise. But I'll just sort of comment on this as a graduate student working with Phil Saul at MUSC that did a finite element model of the AV node consisting of a 25 by 25 array of electronically linked excitable elements. He modeled dual AV node pathways with discrete resistances and time constants for these linked elements, and he defined a fast pathway which has a low resistance and a short time constant, and a slow pathway with a high resistance and a longer time constant. And just to show you, what he was able to show is that this model exuded a nice discontinuity of the conduction curve. It also could produce echo beats and sustained reentry. It also predicted this current flow from the slow pathway to the fast during conduction, and also modeled the effect of ablation by eliminating the slow pathway, shortening the ERP through loss of this depolarizing current. Here's one of their graphs, and I don't want to take you through all of it, but just to sort of show you, similar to the graphs I've shown you before, prematurity here on the x-axis, conduction time on the y-axis. The conduction time through the AV node is here on this curve labeled D, the baseline dual AV node physiology, and then when you've eliminated the slow pathway, you have this new curve here with substantially shorter ERP, similar to what we observe, clinically. So at least this model from about 10, 15 years ago seemed to support that concept of electrotonic inhibition. What are the implications and predictions? A model is an explanation for differential refractoriness, and it invites, in my mind, three predictions at least. The first is that it should be independent of autonomic tone, because nothing about this really brings in the possibility of high adrenergic state is affecting it. The prediction will also be that if you actually do incomplete slow pathway ablation, you should not shorten the fast pathway refractory period, and heart size should be important. So before I get to the heart size thing, just to say, on my theme of AV node reentry being a black box. Okay, so you have AV node reentry, you have a fast pathway and a slow pathway. You would predict that you can't fix AV node reentry unless you get rid of the slow pathway, right? You've got to get rid of the slow pathway. Once the pathway is gone, you should be able to fix AV node reentry. Turns out that every single day in the laboratory, we cure people of AV node reentry and leave them with slow pathway conduction. Why that happens, I don't really know. There's a number of theories about kind of affecting, the different pathways, or affecting the place where they connect to one another. But really, fundamentally, no one really knows. What we know is that we put some lesions in, the patient's better. The electrophysiology changes. Sometimes it doesn't change. Patients seem to do well. We're not really certain why. But there is this large group of patients who we've done successful ablation in, but we have not completely eliminated the slow pathway. So they are, in fact, a group of patients that are very interesting to look at, if this is one of your theories. The last thing is heart size should be important. It seems to me that we're dealing with forces that occur that function over fairly short distances, and it seems like heart size should be an important kind of thing. I just have sort of take a little kind of side thing here. I was actually at the at ISCI. ISCI is International Society of Computerized Electrocardiology. There's a group that gets together yearly to talk about stuff like this. And we were actually in Holland at the Eindhoven Centennial, and I was sitting, and I forget who I was sitting with, but I asked him, what are you interested in? And he said, I'm interested in scale. I said, well, what do you mean? Well, I'm interested in how things change depending on how big you are. You've got rat hearts, you've got elephant hearts, you've got giraffe hearts, you've got human hearts, and how are things, different? And I said, well, yeah, that's great, but I'm sure that there are other important differences between the human heart and, say, the rat heart, in addition to just size. Well, that's true. Turns out that if you're a pediatrician, you got a scale issue, or you have a scale opportunity. We study hearts from 3 kilo kids all the way up to 200 kilo kids, and everything in between. So this is in fact an opportunity, meaning that we've got hearts of all different sizes. Obviously, other things change developmentally, but in my mind, this is kind of a cool opportunity. And it seems to me that heart size should be important, that the magnitude of electrotonic inhibition should be greater in smaller hearts. That's one thing that you would predict. So just to show you just a little bit of data. First of all, the issue of being independent of autonomic tone. As said before, Andrea Natale and Strickberger in '94 they each showed that when you do, in patients who are undergoing EPS and RF ablation under total autonomic blockade, meaning propranolol plus atropine, that the fast pathway ERP still shortens significantly. And as I said, Geller in Cleveland in '98 also showed similar changes. Didn't use total autonomic blockade, but as I said, he painstakingly measured ERPs just before and after each single lesion, and then the changes didn't really happen until you'd actually gotten AV node or gotten fast pathway ablated. You also would predict that incomplete slow pathway ablation should not shorten fast pathway refractory period. And as I said before, we have this group of patients, a fairly large group of patients, where we fix them, their SVT is gone, but their slow pathway conduction is still evident. They even have echo beats. And in these patients, we basically show that in Strickler's article, and in fact in pediatric stuff that we've done, that the fast pathway shortens significantly when you have complete ablation, and it did not shorten significantly when the slow pathway was not completely ablated. And the third thing is that heart size should be important. The magnitude should be greater in smaller hearts. This is the concept that I was saying before about, and this is the argument that I make about why pediatric electrophysiology should be interesting to people that are interested in figuring out how the heart works, because this is sort of my statement, growth and development in childhood is an experiment of nature. We actually have children at all different heart sizes, and if you're interested in what happens as the normal changes of development occur, it gives you sort of that natural experiment of nature. So we can actually have the opportunity to ask and hopefully answer some questions by looking at children. We did a little multi-center retrospective study a few years ago. Got 159 patients pediatric patients undergoing RF ablation at 5 different centers, half older than 13, half younger than 13, 97% successful ablations. To be in the study, you had to have use of AV node reentry. And interestingly, only 62% had this clear-cut dual AV node physiology defined prior to ablation. As I said before, the pediatric population is a little different than the adult population. And we made a lot of measurements just to sort of show that children are different. Their heart rates are faster when they have AV node reentry. That's as you'd expect. When we actually looked at patients who had dual AV node physiology, and in whom we completely eliminated the slow pathway as we defined it, what we found was that in fact we did have this very significant shortening of fast pathway ERP from 342 down to 264. And that difference was very, very large. Actually, it was 80 milliseconds, which is quite a bit different than, or quite a bit larger than what's observed in the adult population. As I said, it's large compared to the adult studies. Of course, this is pediatric population. We didn't have an identical adult population studied and ablated with exactly the same methods. We don't really have a good control group, so I'm a little bit uncertain about how strong this effect is. But in general, in the pediatric age group, our ages ranged from childhood through adolescence, and there was in fact a non-significant trend towards greater shortening with smaller weight. So it raised other issues. Could in the pediatric population perhaps be explained by changes in autonomic tone? Could other factors be important? And could there be better cellular coupling in younger hearts? And does any of this help to explain the increasing incidence of AV node reentry with age? Because like I said, why do we have this in 15-year-olds but not 2-year-olds? One thing that helps us a little bit here is we now have cryoablation. Radiofrequency is a way of basically cauterizing heart muscle, and it works pretty well. But as I said before, 2.5% risk of complete heart block. And perhaps if you're 60 years old, that's maybe not as big a deal. But if you're 3 years old and you get heart block for the rest of your life, you need a pacemaker, that is a big deal. And so in the pediatric world, we very, very quickly embraced cryoablation because it allows us to do a kind of a cryomapping lesion, which is reversible. In other words, as we're freezing, we are watching for any changes in PR interval or AV conduction. And as we're on our way down to -85, if we're seeing any of that, we can stop, defrost, and generally stuff comes back. So it allows us, radiofrequency, the changes occur within a second or so, and they're not reversible. Here, at least for the first 30 to 45 seconds of the lesion, they're reversible. And the freezing spreads very, very slowly. So even 3 minutes into a lesion, if you start to see PR prolongation, if you stop, that area will defrost and will recover. So it's kind of a neat way. But what's interesting from our point of view is that it's completely painless. With radiofrequency, we actually have to do this under anesthesia or with a lot of sedation, because most of the lesions, in fact, are sensed by the kids as heartburn or as chest pain. And you can imagine how that might cause synthetic arousal, faster heart rate, changes in AV nodal conduction. With cryoablation, completely painless and sort of allows us, and also doesn't go as deep, okay? And so it allows us to look at these effects in a different way. And here's some work done by my former colleague, Kathy Collins, who's now in Denver, and a bunch of patients that we had undergoing cryoablation. And as you can see, here's a typical curve with fast pathway and then a jump to a slow pathway, and then following cryoablation, you can see we have this curve where our fast pathway ERP has actually shortened quite a bit. So it seems like the effect is similar. 22 of our patients, in fact, had discontinuous AV node conduction curves, and in those patients we saw a mean change from 275 to 281, similar to what we observed with RF. So it seems like it's not likely to be based on the changes in the synthetic thing. So I'm going to stop here and see if anyone has any questions, comments, advice for me, and just sort of say a few things. Lack of clear dual AV node physiology. It's relatively common in pediatric patients with inducible AV node reentry, so there's something different about them. Measurements of AV node function are clearly age dependent. That's not surprising. We know that kids have faster heart rates. Everything else about the AV node changes developmentally also. This fast pathway ERP shortens substantially in response to complete slow pathway ablation, and that magnitude of change is large compared with reports in adults, and that's an interesting observation. It does not seem to be explainable by autonomic effects. It could be explainable by heart size, but there may be other issues such as coupling, which at least I don't understand very, very well. And I'll stop there and see if anyone has any questions. Right, thank you. I talked fast, sorry. Yes?
How do you explain the shortening in the A2H2 interval? Does that also due to shortening in the refractory period? I mean, the action potential duration and the AV node? I think in the last slide you showed that not only did the ERP shorten, but you also had the shortening of A2H2.
Oh, in terms of the actual conduction time.
Yes.
Yeah, interesting observation. Well, yeah. So that concept, I actually haven't really thought a lot about that. I mean, it does. I haven't thought about conduction time at all, so I don't have an explanation for you. That particular slide does raise the question of whether the autonomic tone is in fact different. Because when you give isoproterenol to somebody, anybody, not just people with AV node reentry, if you give isoproterenol, what happens is that refractory period is shortened, but the AH interval also shortens. Okay, so typical AH intervals are 70 milliseconds, and with isoprel they often shorten to 10 or 20 milliseconds. Absolutely. And I don't have a good explanation for that. Is the fast pathway faster? I can't think of a mechanism for that. Makes me wonder whether, in fact, this concept of autonomic tone is, in fact, much more important in children than it seems to be in adults. And what stopped me from investigating that, quite frankly, is that you can give esmolol, and that's very, very short acting. But to actually give a vagolytic, which would be, atropine, that's actually kind of a long-acting drug. Once you give an atropine, you're sort of stuck with the effects for a couple of hours. And so from a research point of view, great, no problem. From a clinical care point of view, if we want to try to do a clinical study, but also at the same time take care of the kid who's on the table under anesthesia with catheters in, AV node reentry is a bit of a squirrely condition. I hope I've gotten that across to you in terms of all the kind of different conniptions we have to go through to induce tachycardia. Sometimes we get to the laboratory and we can't induce it, or we give isoproterenol and there's only one particular dose at which we can induce it. And if you give atropine, you're stuck with whatever the effects are of the atropine. If the effect of atropine is to abolish your inducibility before you're even underway with your procedure, it might actually adversely affect care. Now, there is a sort of human studies principle at work, which is that, if you take an adult and you do a clinical study, if the adult understands that there may be some risk that, that they might not get the procedure done or something like that, and they agree to that, then you can do that. But you really can't do that in children because they're a different class. They're special class in terms of clinical research, and so the IRB looks much more critically at anything that you want to do in a kid. And if you're doing research in a kid, if it has some potential benefit to the child, that's usually how you sort of get by that. To do this and to have some possibility of interfering with our ability to do a successful ablation, that would essentially eliminate any possibility of getting that through the IRB. So I haven't sort of done that. I don't know of any good vagolytics that are short-acting. If I had a short-acting vagolytic that I could use, then we could do it, and I could basically guarantee there wasn't going to be any bad effect. But I haven't done it. Now, I've been thinking about doing this just on the sympathetic side, because if in fact our concept is that this might in fact be due to elevations in sympathetic tone, and that we're just getting fooled, that I could probably use esmolol just to sort that out, and that would be sort of okay. And so I'm sort of thinking about doing that.
Where do you expect the sympathetic effect to come from?
Well, so the scenario is, okay, so we have changes in AV nodal function as a result of catheter ablation. So one possibility is we've ablated this whole pathway, and that's why it changes. Another possibility is that other things that we've done in part of doing the ablation have changed things in the heart. And so the scenario is doing RF, cause some pain, the child's not completely anesthetized, he sort of wakes up, and has a sympathetic kind of arousal, and that in fact is what changes the AV node. Okay. Another scenario is that they have been on the table for 3 or 4 hours. We haven't kept up with their fluid. They're a little, so all of these different things that it's hard to control for are things that might actually, sort of affect this. And so if you want to really study it in the absence of these sympathetic effects, you need to use, a beta blocker in order to do that. And so esmolol might be kind of, the way to do that. Right? Yes, Samir.
Is there any known animal with dual node physiology or animal model of AV node?
Sure. Well, so there's not an animal model of sustained AV node reentry. There is, I think it's rabbits and dogs, last I checked, right, G? They have echo beats. So they have clear-cut dual AV node physiology and have echo beats. How important those models are for understanding kind of what goes on here is debatable. Because when I take kids to the laboratory for other reasons, like if I'm going after flutter or I'm going after an accessory pathway, we often find dual AV node physiology in those patients as well, and we often will find echo beats. And again, the substrate for this is thought to be these fast fibers and these slow fibers, but those are demonstrable in everybody. So what is it about a particular patient who has dual AV node physiology and echo beats that allows them to have reentry, but doesn't allow the 15% of the population who also has dual AV node physiology to have it? That's really sort of the question. So the rabbit stuff is great, and optical mapping that shows the reentry and sort of shows how it gets from the fastest. That's all wonderful stuff. But it may not, so far, doesn't for me help me understand how you get from that single reentry beats to sustained tachycardia. And even more to the point, what is it we're doing with RF, or cryoablation? What are we doing to the AV node? If we can put a series of lesions at a location that's not the AV node, that's actually transitional cells or whatever they are, kind of leading into the AV node, and have this dramatic effect on a pathway that is a centimeter away, what are we doing? Just exactly what are we doing? Fortunately, we have very few autopsy specimens to actually go and kind of look at this. I was talking to Igor a little bit about the concept of taking hearts that have come out of the out of people for transplants and looking at those, which would sure be fun. But I don't know. I mean, I think, as I said before, AV node reentry is a black box. What we're doing therapeutically to me doesn't make sense based on the model that we are carrying in our heads for what AV node reentry is. And whenever you see that kind of a scenario where you have a model of what a disease is and you have an observation that doesn't fit with the model, it means that there's something wrong somewhere, and it's an opportunity to try to do better in terms of sort of sorting out the model. And that's why my whole sort of thing here with children is that, you know, they are similar to adults with AV node reentry, but they're different in important and interesting ways. And if we can start to look at them, you know, in an intelligent way and with, you know, specific kinds of clinical research protocols, we might actually be able to learn a little bit. So.
How often, when do they go into the arrhythmia? How much of the time are they actually in the arrhythmia? You mentioned you have to induce it.
Yeah, so it's
and
variable.
Is it different with adults?
Yeah, it's different with everybody. I mean, you know, my mother has this, right? And about once every 6 months she gets it. And no one wants to ablate her. I get, you know, 2 months, we see it in younger kids and older kids, and it's all over the map. There are some kids who get it when they lean over. Here's another really interesting thing, okay? So what is it about AV node reentry that means that when you lean over, you know, you go into your tachycardia? That's something, I have a few theories about that, but it's made some kind of autonomic vagal mediated thing that causes a bradycardia and then a junctional beat, I don't know. But,
How about exercise?
and then exercise, right. So that's what I was going to say. So some people go into AV node reentry at rest. Other people, you can't get them into it unless you give isoproterenol, and they only have their episodes when they are exercising or when they've just finished exercising, right? So there's this complex interplay of the substrate, which we don't understand, and then autonomic effects, and other things. So, for instance, one possible, here's what's been told to me by adult cardiologists over the years is that, well, obviously the reason why AV node reentry doesn't mainly happens in adulthood, we don't see very much of it in children, is because to get AV node reentry you have to have a PAC. And most of the time kids don't have a lot of PACs, but when you get to be an adult and you drink some alcohol and you get some atrial stuff, you eventually start to have lots of atrial ectopy, and that's the atrial ectopy that sets it off. So the substrate's always been there, but the atrial ectopy is what sort of happens. Maybe there's some truth to that, I think, but it doesn't really explain what's happening in my patients because they don't have PACs for the most part, and they still go into their tachycardia. They may get into it through junctional rhythm. Junctional beat has the effect of dissociating the fast and the slow pathway and allows you to have reentry. I don't know. But so there's a lot of variability in when they go into it, what things you have to do to get them into it. And just on a day-to-day basis in the EP lab. One kid, I'll go into the laboratory, put a catheter in. As soon as the catheter touches his heart, they get a PAC, bang, they're in their SVT, right? Next kid, I go in there, like this morning, clearly defined dual AV node physiology, classic jump, echo beats, couldn't induce tachycardia in the baseline state. Gave it a lysoproterenol, dual AV node physiology gone. Okay, now we have a nice smooth conduction curve, but at a critical cycle length pacing, bang, we're in sustained SVT. Okay, I don't understand any of that. I mean, I just don't. There's so much variability in this condition.
And what percentage of the pediatric patient has that non-discrete, curve?
The minority, actually, in that one paper I quoted, I think it was going to be 41% or something like that. Less than half. Less than half have the clearly defined jump. Nearly all adults have the clearly defined jump. Children, they have a different kind of jump. They tend to have this sort of crossover concept where you pace the atrium and you conduct to the ventricle, and the faster you go, the longer the conduction time gets, so that eventually you're skipping. This one goes to not this QRS, but the very next QRS, right? That's a more typical thing for children, less often seen in adults. Just one comment to make though is that if you sort of think about it, to get reentry, classic teaching is unidirectional block and conduction delay is what you need. So with AV node reentry, the unidirectional block is blocking the fast pathway. The conduction delay is conduction down the slow pathway with enough delay to allow the fast pathway to recover. Nothing in that says a fast pathway has to be fast, right? No need for the fast pathway to be fast. And so I think what happens in children is when they don't have these discontinuous curves is that their fast pathway is just a lot slower than it is in older people, or conversely, their slow pathway is a little faster than it is eventually. So they have overlap between their two conduction curves. And it's almost like an accident that the fast pathway is fast enough that you can define a jump, right? So we tend to look not so much at the jump, the 50 millisecond jump at A1, A2, but we tend to look at what we call, PR greater than RR, or another way of saying it is sustained slow pathway conduction. If you can have sustained slow pathway conduction, meaning long conduction time, 1-to-1 at rapid pacing rates, that's in fact probably a better definition of what the substrate is. It's not so much you have a fast pathway, it's that you have a slow pathway that's slow enough that the fast pathway can re-enter.
So it's not a mechanism difference at all, really? I mean, the mechanism you would expect to be the same.
Right, I think so. Yeah, I think so. Right. Yeah.
With the disability of AV nodal RT depends from refractory period and conduction delay. So
I'm sorry?
can you calculate in wavelengths for re-entry? Can
I'm
you
sorry?
calculate wavelengths for re-entry? So how indisability of
Calculate.
re-entry depends from refractory period of both fast and slow pathway and conduction.
Right.
So AH conduction. How it depends. So if you have shorter refractory period of slow pathway, you will induce more
How is
re-entry.
inducibility related to the relative refractory periods in
Oh, I see.
conduction
Yeah,
velocity?
so you're talking about sort of the window is what you're talking about,
Exactly.
right? The window between the fast pathway and the slow pathway. Never actually looked at that. It's our general impression is that you kind of need a long window. Or most patients, in fact, have a long window. When we often in normal people will define a classic jump just before we hit the AV node ERP. So you'll sort of be marching your way down, and you'll get to a particular A1, A2, and you'll suddenly have a 50 millisecond jump, and you say, you get all excited, and so we get to electrophysiology, and the very next one blocks, right? So maybe that's like a narrow window, and those patients generally don't have AV node reentry. So I don't know if I'm answering your question, but it's just sort of a clinical impression that we have is that patients who actually have the disease rather than just the normal variant, tend to have a very broad window. Okay, so like once they're on their slow pathway, they're on it for a long time, all the way down. Okay, they tend to have a lot of opportunity down that slow pathway, and maybe it's related. Refractoriness and consistent conduction are kind of different concepts. They're related, but they're different. But it's somehow, I think, related to that fact that you have a slow pathway that's capable of very consistent conduction. You can get very, very premature and still be going down the slow pathway. Does that answer your question? Okay. Yeah. I mean, I think people on the adult side have looked carefully at that question of, how much of how a window do you need between the fast and the slow? I would predict that whatever findings one has, they're probably different depending on the autonomic state. So you can have you can have variations in the window. And actually, this actually may go a little bit to your question. When we're trying hard to induce AV node reentry in the laboratory, we are in patients who are difficult to induce. We often go to a high dose of isoprel and try to induce there. And then if we fail, then we'll turn off the isoprel. And as the isoprel wears off, we are continuously banging away with pacing. And the way I think about that is that we're exploring.
Are you doing this one as two protocol or just this one as one? How do you use re-entry?
For that particular technique, I tend to do burst pacing at around the AV block cycling. So it's sort of like a bioassay. So typically, we give some isoprel, we're not inducible. So then I turn off the isoprel. Say our AV block cycle length was 230 or something like that. As the isoprel starts to wear off, 230 no longer conducts, and so 250 is where the AV block cycle length is. And then wait another 2 minutes, it's 280, and wait another 2 minutes, it's 320. And as we go down, we're testing all these different levels of isoprel on the way back down to kind of baseline. And sometimes, this is actually sort of my standard post-test maneuver. If I really think I fixed the patient, give them a big dose of isoprel, pace them. If they're cool, then I turn it off, and then what we call chase them down. Pace them, on and off, on and off, on and off, as the isoprel is wearing off, searching for a zone. And so the way I think about that is that isoprel affects both the fast and the slow pathway, and it does contradictory things, right? So will shorten refractory period of both the fast and slow pathway. So if it shortens the slow pathway refractoriness, that's a good thing. But if it shortens the fast pathway refractory period, it's not a good thing. It makes it less inducible, right? It also shortens conduction time, right? So if it shortens conduction time more than it shortens slow pathway refractory period, you may actually interfere with the ability of inducibility, because conduction time gets so short that, you know, it catches its tail, okay? And so the concept is that there's going to be some critical dose of isoprel where the window, I guess, I don't know if that makes sense, is there. So, and it's a variable thing, and we see it's different in each patient. Yes, Jean?
Why does the cryoablation not cause AV block when the normal ablation does?
Well, it's perfectly capable of causing it. The difference is how slowly it goes, and that the changes, you know, there's kind of a two-step change between, you know, freezing the cells so that they're non-functional to freezing the cells where they're dead. And so you go through this phase where you've essentially stopped the electrical activity without killing the tissue. And at that point, if you defrost, it comes back. Now, if you go through too many cycles at the same spot, sooner or later you've killed it. But in general, you know, it's, in addition to it being very, very gradual and be able to see the effects happening slowly, there is that phase where you've you know, inactivated, or you've stopped the function of the cardiac cell without actually killing it. So, good. Thank you very much. Okay, good.
Recently in the fall from a joint appointment at UCSF.
Papers in the last decade that kind of talk about our current extensions, meaning little bits of AV nodal tissue, and we know that for any sort of 10 millisecond decrease in the coupling, you have a discontinuity in that conduction curve, and a jump is most of the time we see a 100 millisecond or 120 millisecond jump. To a situation where the PR is actually greater than the RR, and what I mean, and the criterion is a VA time during tachycardia of less than 50 milliseconds. And then at the coronary sinus os, which is again where the here's a typical conduction curve, and actually this is pretty typical for what we see. In fact, I took this off of one of my patients, and we're coming backwards up. We're on this sort of new curve. So the general concept is here we're on the slope up here, basically 4 surface ECGs, high right atrium. The concept is we're blocking in the fast, going down the slow, but still no echo beat. But then as we factor in the extra electrogram here on the HIS, which is transesophageal electrophysiology study. So when, you know, normal electrophysiology study close enough to the left atrium that we can actually read simulation from the esophagus and actually define this. But even with TE electrophysiology, example of what we tend to look at, this is called the Hasegawa potential from the pathway. With AV node reentry, this is a non-specific finding. So it gives you some sense that you're at the place where you're likely to have. Here's just an example of what the catheters look like in the heart. Here's an LAO view, and close to the septum here, probably the coronary sinus os is around here, and here we are. People have reported this for a long time. Here is kind of a decade. And here what we're doing is we're comparing the fast path. You shorten the refractory period of the fast path. You give propranolol and atropine. These effects are still seen, and that's something that Andre Natali demonstrated. On the y-axis, the conduction time through the AV node is so. At least this model from about 10, 15 years ago, when we actually looked at patients who allows us to do a kind of a cryomapping lesion, which is reversible. In other words, that we can stop, defrost, and generally stuff comes back. So it's a neat way. But what's interesting from our point of view is that it's completely painless. Collins, who's now in Denver, and a bunch of patients that we had. 22 of our patients, in fact, had discontinuous AV node conduction curves, and in those patients we saw. And I'll stop there and see if anyone has any questions. Right, thank you.
A2H2 interval, does that also do to shortening in the...
I really think I fixed the patient, give them a big dose of isoprel, it goes, and that the changes, you know, that phase where you've essentially stopped the electrical activity, you know, it's, in addition to it being very, very gradual and be able to see the effects